So our topic for discussion today is aortic aneurysm with the nursing care and considerations involved. My name is Jennifer Ryan.
And I'm Brianna Crivero. Okay, so the video objectives for today are going to be the anatomy and physiology, which will include what is an aortic aneurysm, what are the classifications of different aneurysms. The second video objective is going to be the nursing care and process, which will include assessment findings, planning care, interventions, and evaluating goals. And then finally, we're going to finish with Healthy People 2020, which will include evidence-based nursing and screening tools. So first, we're going to start out with the anatomy and physiology of what is an aortic aneurysm. So here we have a picture right here, and this is your aorta. This would be your ascending aorta, and coming down would be your descending aorta. If you were to have an abdominal aneurysm, it would be in here, and thoracic would be further up, obviously in the thoracic region. The definition of an aortic aneurysm is a permanent localized outpouching or dilation of the vessel wall. Some causes and risk factors for an aortic aneurysm include degenerative, congenital, mechanical, which includes blunt trauma, inflammatory, which is aortitis, infectious, which could be caused by chlamydia, pneumonia, or HIV. Some risk factors include age, male gender, hypertension, coronary artery disease, family history, high cholesterol, lower extremity peripheral artery disease, carotid artery disease, previous stroke, tobacco use, and excessive weight/obesity. And the three primary risk factors have been starred, which are age, male gender, and tobacco use, which puts you at most risk for having an aortic aneurysm. And here's your picture of your elderly man who's smoking, who's also Caucasian, which is also another risk factor. So there are different classifications of aortic aneurysm. So a true aneurysm is when the wall of the artery forms the aneurysm with at least one layer of the vessel intact. There's two different types of shapes. There's the fusiform shape and the saccular shape. So the fusiform shape is when it is more like a ball, and the saccular is when it kind of outpatches like this. And then there is a false aneurysm, which is also known as a pseudoaneurysm, and it's not considered an actual aneurysm. It's a disruption of all of the layers within the bleeding that is contained by surrounding anatomic structures. So for clinical manifestation and assessment findings, for a thoracic aortic aneurysm, the patient is often asymptomatic. They can express that they have deep chest pain that may radiate back to the scapula. They may have jugular vein distension. They may have dyspnea or stridor, edema of the face or neck, or dysphagia. And then for the abdominal aortic aneurysm, the patient most often will have it occurring below the renal arteries. The patient can feel his or her heartbeat while laying down. Burwitt's may be auscultated over the aneurysm. The patient may exhibit blue toe syndrome, which is when the feet or toes are mottled. The patient may also complain of back pain, epigastric discomfort, and altered bowel elimination. So some diagnostic studies for the patient that you believe has an aortic aneurysm include a CT scan, which is your number one diagnostic study that can be used to determine whether or not this patient does indeed have an aortic aneurysm, a chest x-ray, a TEE, abdominal x-ray, ECG, ultrasound, MRI, and angiography. The ECG is mostly to rule out whether or not the patient is having an MI. So this right here is a CT scan. It's a transverse view, and you can see the enlargement of the abdominal aorta. And this picture over here is this big mass right here is what it would look like in an actual patient when they had an abdominal aneurysm. So for the surgical interventions, there is open repair, and there's also endovascular repair. So I have a picture right here, and it shows you that the aorta is proximally and distally clamped to restrict the blood flow. The diseased area is then cut out by the surgeon. Plaque can be removed. They take a synthetic graft and then they suture it proximally and distally to the aneurysm itself. And then sutures are placed in the aortic wall and around the graft. Bifurcated grafts used if the iliac arteries are affected. Excision of the bulbous region for saccular aneurysms is also what they can do during an open repair. So, like I mentioned before, there's an endovascular graft procedure, which is less invasive. What happens with that is the patient must have patent iliofemoral vessels, which is like down here, so that they have safe insertion and are sufficient in length and width. A sutureless graft is inserted into the abdominal aorta via femoral artery. A balloon is inflated, therefore deploying the endovascular graft to the aortic wall. Blood flow occurs through the graft. This picture over here, it's kind of like the Chinese finger lock thing, where the one piece is inserted and then they blow it up and they kind of pull it through the vessel, and then the second piece is added into the other femoral artery. Okay, so some nursing assessments you can do on patients who have an aortic aneurysm include assessing for cardiac, pulmonary, cerebral, and lower extremity vascular problems, monitoring for signs and symptoms of aneurysm rupture through focus assessment, peripheral pulse checks before and after surgery, and right here I have just another scale of peripheral pulse checking. And you want to make sure that you check both the pedal pulse and the dorsus pedalis or pedis pulse. So for this patient, you want to have good planning, which means that you want to have goals for them. The number one goal you want to have is to maintain normal tissue perfusion. The second one being display intact motor and sensory function, because you are going in through their femoral arteries for the endovascular graft, and if they are getting the open repair, you're also cutting open their, depending on where their aneurysm is, you're cutting that open. And the third one is to display no complications such as infection, thrombosis, or rupture after surgical repair. So some nursing interventions pre-operatively. You're going to give emotional support to the patient and the family. You're going to provide education about what's going to go on during the day, before surgery, after surgery, expectations, questions, concerns, rehab, things like that. You're going to want to administer the bowel prep as prescribed 24 hours before surgery. You also want to make sure that you do the skin cleansing with your patient before they go into the OR. Make sure your patient is maintaining an NPO status, and you are going to give prophylactic IV antibiotics. Post-operatively, the patient is going to be in the ICU for about 24 to 48 hours. They will have an ET tube. They'll also have an arterial line. You'll be doing CVP or PA monitoring. They'll obviously have peripheral IVs. They'll have a Foley catheter, NG tube, continuous ECG monitoring, and a chest tube if the patient has the aortic repair in the thoracic region. They will most likely have a chest tube, and also PCA pump for pain management.
This is where I come in, right?
Yep.
Okay. Awesome job.
Oh
That was
my
really
God.
good. That was really good. Whew. So next is the acute intervention of the aortic aneurysm. With the graft patency, you want to maintain blood pressure to ensure patency of the graft. You also want to administer and maintain IV fluids and blood components as ordered to maintain the MAP. You want to monitor CVP and PA pressures, also the urinary output, and administering IV diuretics, antihypertensive meds as ordered to correct any hypertension that's occurring. Cardiovascular status. You would monitor for MI during the perioperative phase. You also want to monitor the EKG for dysrhythmias. Also keep in mind to monitor the electrolytes, take an ABG, and administer cardiac meds as ordered and as appropriate. And you want to maintain pain management. For infection, you obviously, number one thing is hand washing to prevent the spread of infection. Administer broad spectrum antibiotics as ordered and prescribed, finish them all the way to the end. Assess for the patient's temperature, the white blood cell count, the surgical site. You want to make sure that that is free of purulent drainage. Perform wound care as ordered, and use of aseptic technique when handling the catheter insertion sites, so making sure not to introduce anything in that way. And lastly is your gastrointestinal status, which you would maintain the nasogastric tube to low intermittent suction, provide proper oral care frequently, assess for bowel sounds every 4 hours, and encourage early ambulation, as well as assessing for bowel ischemia, which are the following 6 things. So absent bowel sounds, fever, abdominal distension, pain, diarrhea, and bloody stools. So with the neurological status, you want to assess the level of consciousness of the patient, as well as their pupils for size and symmetry. You want to also check their facial symmetry as well, their tongue positioning, speech, upper extremity movement, hand grasps, lower extremity assessment, just making sure that they're neurologically intact. Their peripheral perfusion status, peripheral pulse checks are done hourly. As Brianna had said, it's your pedal pulses as well as your dorsal pedis pulse. Your ascending aorta and aortic arch involvement. You would also assess the carotid, the radial, and temporal arteries. And then with the descending aorta, it's, as I just mentioned, your femoral, popliteal, posterior tibial, and dorsalis pedis. You want to assess the skin temperature, color, and capillary refill with CMS. And pulses may be absent pre-surgery due to coronary artery disease, so keeping that in mind. Assessing for the baseline pulses prior to performing the surgery, and also to note any changes post-operatively. And lastly, we have the renal perfusion status. You would assess the urinary output every hour, monitor the BUN and creatinine daily, again for the kidney status, the CVP and PA pressures to determine hydration status, and also decreased renal perfusion may occur if aortic thrombus plaque embolizes, causing ischemia to the kidneys. And measuring the daily weight. Okay. Discharge teaching. So first you want to evaluate your originally set goals with the patient. Teach the patient to avoid heavy lifting for 6 weeks after the surgery. Redness, swelling, increased pain, fever above 100 degrees should be reported to physicians, so your signs and symptoms of infection always should be reported right away. Teach the patient how to check extremities for perfusion, warmth, pulses, etc. So your CMS checks. And recommend counseling if sexual dysfunction exists post-operatively. Okay. Evidence-based nursing. You'll assess the signs and symptoms of the patient. So if they're asymptomatic, you'll report this to the physician to prevent any unnecessary repair that could cause further complications. So basically, if the person isn't experiencing any symptoms, there's really no need for repair because it could make their condition worse. And as Brianna had mentioned in the beginning of the PowerPoint, the risk factors of a patient would be a man of the ages of 65 and older that has a history of smoking. And you also would assess the effectiveness and benefits of screening specific populations. One of the things that you would do in the event of evidence-based nursing is administering appropriate medications for hypertension, so beta blockers, preoperatively for people with cardiovascular disease. ACEs and ARBs are used to prevent further abdominal aneurysm expansion. You want to then, of course, manage the signs and symptoms versus repair. So keeping in mind as a nurse what signs and symptoms are occurring and maybe suggesting to or bringing up to a physician that an emergency situation is occurring, that they may need surgery, or recommending that they do not take the surgery because they do not have any symptoms. So, teaching, also you would want post-operatively to teach a patient to quit smoking, increasing exercise, and also moderate physical therapy is recommended for patients that have AAA. Screening tools. Our screening tools would be an ultrasound, which is used to screen for AAA. There's one-time screening recommendation, and the highest recommended patient is, you guessed it, a male, 65 and older, with a history of smoking, and they also recommend it strongly, but not as highly, for a male that is 65 to 75 years of age that does not smoke. Women are not recommended to get the screening because it's a lot of times unnecessary, and they typically do not routinely have this condition.